T3 are used in some settings but are not universally available and are not standardized. Antimicrobial antibody test is used to diagnose autoimmune thyroid disease. Neonatal screening for hypothyroidism. Screening of all infants with TSH and T4 should be performed between 2 and 4 days of the birth. TSH 25 ml unit per liter is normal in neonate. More than this, suspected to hypothyroidism. What is subclinical hypothyroidism? Subclinical hypothyroidism is a state where the TSH is high and the T4 and free T4 is normal. The findings can be used combined on repeated tests after 4 to 6 weeks. It is the laboratory diagnosis. Clinically, patient is asymptomatic. However, clinical features is present, then treatment is to be started. Indication of treatment in subclinical hypothyroidism. Following hemithyroidectomy, presence of diffuse or nodular goiter, dyslipidemia, diabetes, infertility, pregnancy, depression, symptoms like dry skin, poor memory, muscle weakness, tiredness, muscle cramps, cold intolerance, hoarse voice and constipation. Now I would like to Vaidehi to continue with the treatment and prevention of hypothyroidism.
Good afternoon everyone. I will continue with the next part of the topic, that is treatment of hypothyroidism. As we all know, the treatment for hypothyroidism is hydroxyl. Once treatment is started, TFT should not be repeated till 6 weeks because medicine takes 6 weeks for the levels to become stable. In special cases like heart disease or elderly patient, start with a lower dose, later 6 monthly review and then annual checkup is adequate. Aim of the treatment is to keep TSH at the normal range. Conditions in which T3, T4 is normal and TSH is very high despite of the therapy. If patients T3, T4 levels are normal but TSH remains high, it means mostly the patient is not taking treatment, that is non-compliance. Maybe thyroxine is not getting absorbed due to some reasons. That reason we will discuss in the next slide. Maybe the drug has lost its potency. Thyroxine should be taken daily every morning on an empty stomach. It can also be taken 3 hours after dinner, which is not commonly followed. On the day of thyroid test, morning dose of tablet should be omitted. If medicine is already taken, TFT can be done after 4 hours. Conditions interfering with thyroxine absorption. Thyroxine absorption is decreased by conditions of the gastrointestinal tract like celiac disease, inflammatory bowel disease, H. pylori infection if patient has, and atrophic gastritis. Also, if medicines like proton pump inhibitors, calcium carbonate, ferrous sulfate, aluminum containing antacids, phosphate binders, etc. What is secondary hypothyroidism? What happens in secondary hypothyroidism is the TSH will not increase for low T4. Also, patients will not show symptoms such as weight gain, pale skin or goiter, etc. The most common manifestation is hyponatremia, followed by underlying pituitary tumor or other pituitary hormone deficiency may be present in secondary hypothyroidism. Hypothyroidism can be seen in women in 3 important time periods, that is pre-pregnancy, pregnancy and postpartum state. Pre-pregnancy hypothyroidism is the major cause of subfertility, that is decreased fertility. How is it caused? It causes ovulatory dysfunction, hyperprolactinemia due to increased TRH production, inadequate corpus luteum, altered gonadotrophic releasing pulsatile secretion causes delayed LH response. Low TSH in first half of pregnancy is normal, but high total T4 level is because of estrogen-induced increase of thyroxine binding globulin. More thyroid binding globulin means the more bound T4. Therefore, total T4 is high, but free T4 is normal. This slide shows the difference in total and free T4 in pregnancy and non-pregnant status. In pregnancy, free T4 is 0.8 to 2 nanogram per dl, and in non-pregnant range 0.8 to 2 nanogram per dl. Total T4 is 7.5 to 18 nanogram per dl in pregnant range, and non-pregnant it is 5 to 12 nanogram per dl. This is the TSH target should be in pregnancy. During first trimester it should be 0.1 to 2.5 microunits per ml. In second trimester it should be 0.2 to 3, and in third trimester 0.3 to 3 microunits per ml. Effects of hypothyroidism on pregnancy. In pregnancy, hypothyroidism may affect both mother and child adversely. Impaired neurocognitive development of fetus, low birth weight, miscarriage, gestational hypertension, etc. can happen due to hypothyroidism. So what is the treatment of hypothyroidism in pregnancy? The dose of thyroxine in pregnancy depends on the subclinical or over hypothyroid status. In subclinical hypothyroidism, the starting dose of thyroxine is 50 microgram per day, while in overt hypothyroidism, the starting dose is 100 to 150 microgram per day. Previously treated hypothyroid patients with newly detected pregnancy should independently increase the dose of leothyroxine by 25 to 30% upon a positive home pregnancy test and report to the doctor. Some facts of hypothyroidism. Dyslipidemia can be associated with hypothyroidism, so hypothyroidism is to be treated before starting statin therapy. Both hypothyroidism and statin therapy can cause myopathy due to rhabdomyolysis, so TSH to be estimated in patient on statin therapy. Low sodium level is also associated with hypothyroidism. The reason is unknown. It may be due to inappropriate ADH secretion, which prevents excessive water loss to in urine. It may also be due to a decrease in glomerular filtration rates, which happens when the kidney is under stress. Hyponatremia is associated with hypothyroidism and is treated with thyroxine replacement. What is myxedema coma? It is an uncommon but severe form of hypothyroidism which has generalized ill effects. It usually occurs in elderly women who often stop their medicine on their own. Some patients may present with coma, some may present with confused state, or we call it delirium. The reasons for myxedema coma are hypothermia, presence of infections, cerebrovascular accidents, congestive heart failure, drugs like amiodarone, anesthetists, psychotropics, gastrointestinal bleeding, metabolic conditions like hypoglycemia, hyponatremia or hypoxemia. Clinical picture of myxedema coma. Patient can present with bradycardia, patient with